Welcome to The Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about cervical radiculopathy, otherwise known as a pinched nerve in the neck, the imaging findings on an MRI, as well as presentation and the physical exam findings of somebody that presents with a pinched nerve in the neck to my clinic. I'll be posting new videos weekly, so hit the subscribe button to catch them as they come out. Before we get started, I thought I would review some very basic terminology. Some words you might see when you see your spine doctor is cervical. Cervical means neck. We already described that to you. And stenosis. Stenosis is just a very fancy word for narrowing. Anything could be stenotic. The doorway could be stenotic. A highway could be stenotic. It just means narrowing. And in the case of the neck or cervical spine, it means narrowing of the space for either the nerve or the spinal cord. If you reviewed the last episode talking about cervical spine anatomy, you'll remember that the nerves come off of the cervical spine and off of the spinal cord. So the spinal cord is this yellow thing in the back, and there are nerves that come off of the spinal cord. So these nerves come out through these windows, and the window is called the foramen. Cervical stenosis, which is narrowing of the space for the nerve or cord in the neck, can be a little bit more specific when you call it cervical foraminal stenosis. So foraminal is the location, and that's all it really means. Cervical foraminal stenosis, or narrowing where the nerve comes out, causes cervical or neck radiculopathy. And that word radiculopathy sounds long, sounds hard to say, but radiculopathy just means pain in the distribution of the nerve being pinched. Patients that present with a pinched nerve typically can have neck pain, but almost always have pain by the shoulder blade coming down the arm. And in order to understand why, I thought we'd talk a little bit about the anatomy of the cervical spine. So this is looking at the right side of somebody. These are the nerves coming out of the foramen, and all of the nerves in the cervical spine, particularly the lower ones, the C6, C7, C8, and T1 nerves, they come down and they all come together underneath the clavicle, and they come down your arm in a giant band. So here's a more specific look at it. So these are the nerves coming off of the neck. There's a C4 nerve, C5 nerve, C6, C7, C8, and that's the T1 nerve. These nerves all come down, but each nerve does something very different. And in order to understand where patients can get pain from a pinched nerve, you really have to track where each of these nerves individually go down the arm. The nerves that are responsible for the shoulder and down the arm typically include the C5, C6, C7, C8, and the T1 nerves. Now, nerves in general serve two very basic functions. The nerve supplies sensation, which is why when somebody has a pinched nerve, they can get pain in the distribution where that nerve normally causes sensation, and they can also get weakness because each nerve does something different, and each nerve supplies a different muscle in the arm. And this is why when people have a pinched nerve, they can present with two very basic things. One is arm pain in the distribution of the nerve and where the nerve goes, and the other is weakness. So let's talk about sensation first, where each nerve supplies. So this is something I like to spend some time on. We'll actually start with this right side, which is the front back view. It's called the anterior view, which is looking from the front. So this is the patient's right side, and the patient's looking at us. So this is the corresponding posterior picture, meaning looking from the back. So this is the back of the skull, there's the back of the ear. When somebody comes in and they tell me they have arm pain, and the arm pain is coming from the upper shoulder blade, coming down the arm and going to the thumb, that's pretty characteristic of the C6 nerve. Let's talk about the C7 nerve, which is the next most commonly compressed. The C7 nerve typically goes down the back of the arm, what we call the posterior aspect of the arm, and can reliably go into the middle finger. The C8 nerve comes down inside the forearm, goes to the ring and small finger, and the T1 nerve goes into the armpit and kind of comes down. What I want to point out is C6, C7, C8, and T1 Again, very commonly pinched nerves, even though anatomically they kind of live up here, the nerves come out here. the referred pain is often to the back of the shoulder blade. This type of shoulder blade pain, we have a name for it. It's called periscapular. Peri meaning around, scapula meaning kind of that angel wing behind the scapula. Each nerve not only does sensation, but it also does muscle strength. The C5 nerve typically goes to the deltoid, which is the shoulder muscle. The C6 nerve goes to the biceps muscle and also the wrist extensor muscle, meaning keeping your wrist extended like that. The C7 nerve is a triceps muscle, so this muscle back here, people that have a weak C7 nerve can't do a push-up because of the triceps weakness. The C7 nerve also goes to the finger extensors and also goes to the wrist flexors. The C8 nerve typically is grasp strength, and T1 nerve we call as the interosseous, which is the ability to kind of spread your fingers wide apart and push them together. Again, we'll show all this on a physical exam. A pinched nerve of the neck caused by cervical stenosis. Stenosis, again, is a narrowing of the space. Really, 95% of the time comes from two things, and that is either a disc herniation or a bone spur. This is the cervical spine, and we'll look at this level here. What will happen over time, as that disc degenerates, gets flatter with arthritis, that little corner develops a spur, and a spur is really just an outgrowth of the bone. So what can happen is, as the bone grows out, it can pinch the nerve. The other thing that can cause stenosis is a disc herniation. So that's the disc. The disc is like a jelly donut. The donut layer can tear and the jelly can spit out, and the jelly itself, not a bone spur, can narrow the space. Sometimes it's a combination of a bone spur as well as a disc herniation. That's usually often the case. You'll typically see it on a radiology report called a disc osteophyte complex. So let's look at what the MRI looks like. This is the MRI of a patient of mine that presented with right-sided arm pain. Her pain was in the shoulder blade coming down her arm, going to the thumb and index fingers. So immediately I'm thinking the C6 nerve. Here you'll see the base of the brain, and there's a spinal cord coming down. That white stuff is the cerebral spinal fluid. So my patient actually had plenty of room for the spinal cord. There may be a little bit of disc bulge there at C6-7, but really not that bad. So we're looking where this red line is. So C2, C3, C4, C5, C6. It's the C5-6 level. So here's a cross section of the disc. So there's a spinal cord, that gray thing here. The white stuff is fluid around the cord, and the foramen is this corridor, this area. So you'll see on the left side, that faint gray thing is the nerve coming out. And that's supposed to be representative of that yellow thing coming out. On the right side, you're looking at this area, and you can see there's a pretty big bone spur coming off here, and it's narrowing this space. You can see how this gray area kind of hourglasses here, which this area is straight. So this is a really good look at what foraminal stenosis looks like. And I'll mention at this point that the nerve that's getting pinched is named by the level below it in the neck. Meaning, if this is the C5-6 level, the nerve here is the C6 nerve. Another great view is called the foraminal view. This is a view that a lot of MRI centers don't get. We happen to get it. I think this is one of the best ways to look at a pinched nerve in the neck. Again, this is the side view of the neck, but instead of a straight side view, what this is a foraminal view, meaning what we've done is we've rotated the neck 45 degrees so that we're looking end on into each foramen. So these are the windows that the nerves are coming out of here. These are the foramen. You can still see the discs here. And here at C5-6, you'll see it's not open and it's got this narrowed kind of hourglass appearance. This level, if it were open, should look like this, nice and open, and this nice and open. You can see it's because of a disc osteophyte complex, meaning there's a disc coming off, and the osteophyte is this little bone spur, and this is the great look of a bone spur off of the C6 bone coming down. You can see it jamming that gray thing, which is the C6 nerve. One thing that's fairly common when people present with a pinched nerve in the neck is that they like to walk around like this. And that's actually a physical exam sign. It's called a shoulder abduction sign. And the reason patients like to do that is because the nerve is like a bowstring. The nerve is a dynamic structure, and the nerve actually flosses in and out of this foramen. And I already showed you that the nerve goes all the way down the arm, and terminates in the fingertips. So what happens when the arm is extended or when the neck is moved, that nerve is a fluid structure and is flossing in and out of the foramen by 1 or 2 centimeters. So obviously a nerve on tension is going to be a nerve that's in pain. So the longest position for the nerve is going to be arm extension, and the shortest position for the nerve is going to be like this, because you're shortening the length of the entire nerve. What's important to me when somebody has a pinched nerve, and what can really affect outcome, affect urgency of what we do, is how much weakness they have. So doing the strength exam is really important when patients present with cervical radiculopathy. I'm going to show you a fairly typical exam for the cervical spine, which begins with looking at range of motion in the neck. It goes through something called the Sperling sign, and then it goes through a strength exam. Typically during the exam, I'll also ask where patients have pain. Okay, so this is the cervical spine exam. First, we check for normal range of motion, so bring your chin down. This is a cervical flexion. Bring your chin up as much as you can, that cervical extension. Look straight. Look to the right, that's right rotation. Look to the left, that's left rotation. So he has fairly normal range of motion. Look straight ahead for me. The first test for a pinched nerve is called a Sperling sign. A Sperling sign is trying to reproduce the nerve getting pinched in the foramen. So if this is the cervical spine like this, if a nerve is getting pinched, when he looks up and looks this way like that, what it does is it pinches down on the nerve in question. So the Sperling sign is, I'll have you look up as much as you can, look to the right, and I'll usually hold you here, putting pressure this way, and that's forcing pressure on the nerve, and look straight ahead. Next thing I'll do is ask him where his pain is.
So sometimes it starts in the shoulder blade back here and then travels down my tricep, backside my arm, and then into my hand.
Okay, so that's fairly classic C7 nerve. So let's just see where your pain is with a Sperling sign. So we're gonna have you look up, look to the right, and I'm gonna hold you up here for a few seconds. So a lot of patients with a C7 pinched nerve, show your back here, will have pain by the shoulder blade here. So look up and to the right. So sometimes it'll reproduce pain right in here. C7's anatomically up here, but it refers pain to the shoulder blade. So that would be the Sperling. So look ahead for me. So let's do the Sperlings again and trace out where your pain goes when I do this.
It starts here and then travels around down my arm and then into my fingers here.
Okay, so look straight ahead for me. Let's test your strength. Bring your arms up like that, nice and strong. It's C5, so we'd expect that to be strong. Arms in like this, C5, 6, we'd expect that to be strong. Arms straight, this side's strong. And on this side, it's a little bit weak. So that weakness represents a pinched C7 nerve. C7 goes to the triceps. Fingers nice and straight, so it'll be strong on this side probably. And on this side, a touch weak. And then make a fist, cock your wrist up, and this should be strong, that's C6. And then cock your wrist down, that's strong there. And I expect this to be slightly weak. Fingers wide apart, I expect this to be nice and strong, because that's T1. And then grab my fingers, that's nice and strong. Okay, that's good. Cervical exam. Thanks for watching. Don't forget to click the like button and leave questions or feedback in the comment box below. Hopefully you learned a little bit about cervical radiculopathy, otherwise known as a pinched nerve in the neck, and some of the physical exam findings and imaging findings that your doctor may show you. On the next episode, we'll talk about all the non-surgical things you can do to treat a pinched nerve in the neck, including physical therapy, epidurals, cervical traction, as well as medication. And of course, we'll also review what surgical options exist. Feel free to let me know what videos you would like to see in the future.